Good afternoon, everyone. My name is Stanley Chang, and welcome to our webinar series, Our Homes, Ending the Housing Crisis. Today, we're thrilled to have three special guests joining us from the state of Arizona, addressing one of the most important topics of our time, homelessness. Our guests are Alex Dayman, Liz Costa, and Shreya Arakere from the Arizona Healthcare Cost Containment System, or AHCCCS. AHCCCS is Arizona's Medicaid agency that offers healthcare programs to serve eligible residents. It has successfully applied for and is in the process of renewing their Medicaid Section 1118 waiver for their Housing and Health Opportunities, or H2O demonstration program, which provides housing services and interventions for Medicaid recipients who are homeless or at risk of being homeless. And so for our audience, we're going to be taking questions in the chat function below. So if you have any questions, please feel free to join in by submitting them in the chat, and we'll try to get to as many as we can for our panelists today. And so let's begin. Thank you so much for joining us, and please take it away.
Awesome. Thank you so much. And we're thrilled to be here today with you, talking about one of, I think, our favorite initiatives to discuss these days. It's the exciting stuff that we get to do as civil servants and as Medicaid employees. So you saw the names and the titles on the screen. As Liz and Shreya chime in, I'll let them introduce themselves in the interest of time. But my name is Alex Dayman. As was mentioned, I'm an assistant director here with I won't reiterate our whole name because we're I don't know, at the top of the list on our acronym soup that we live in, but we call ourselves Access here in Arizona. So we are Arizona's Medicaid program, and we're really excited to be able to delve a little bit further into the housing space, which has historically not been able to be reimbursed in a really significant way historically under the Medicaid regulations. So I'll pause for a moment. Teresa, do you have the slides, or would you like me to present them? I'm happy to do so, if so. Ready? I'll pull them up now. Folks can let me know when they see the slides on the screen. Good to go? All right. So there are a lot of different ways to address social determinants of health, and just to kind of level set around what social determinants of health are. I'm also going to be using a term called health-related social needs. So those are kind of the two buzzwords in this space, HRSN and SDOH. Really what those are the factors outside of what we would historically consider as healthcare from a kind of a legacy perspective. These interactions with your doctor, with your psychiatrist, with a hospital, etc. This is what those things are what Medicaid and health insurance coverage options have historically paid for and historically been in the business of covering. But a few years back, I mean, almost a decade ago now, some literature started coming out that indicated that really those interactions only result in about 20% of the health outcomes, or only are attributed to about 20% of the health outcomes of the entire member, right, of that whole person. So when we started seeing those data trends, we started saying, we as the healthcare community started saying, okay, well, what factors outside of just those healthcare interactions are impacting the member's health? And you can see them on the screen: socioeconomic factors, education, job status, family, income, if you're able to live in a safe environment, your physical environment, the pollution that you're exposed to, and then your healthy behaviors, right? So these activities, these lifestyle choices that members make, diet and exercise, tobacco use, alcohol use, sexual activity, etc., all can have varying impacts on the entirety of a member's health, right? The entirety of that whole person. So realizing that as America and definitely in our state, we were seeing health outcome trends kind of go in the wrong direction. We really took a look and said, what more can we do as Medicaid, given that we are such a significant source of funding for so much of the system? What more can we do, to make those, to amplify those efforts that we're currently involved in around treating the whole person? And what more can we do to implement additional interventions, initiatives that can have an impact, maybe in a disproportionate positive impact on the members' health outcomes, on their experience, on their ability to live a happy, healthy life. So that's kind of the concept behind why you're seeing Medicaid programs and other health insurance option programs start to dip their toes into things like housing, into things like food insecurity, transportation insecurity, help with education, help with ensuring that there's access to legal supports if that's what the members are coming up against as a barrier to ensuring that they are able to access healthcare in a significant way. It's really hard to think about going into getting those kind of preventative services, those lower cost preventative services that would really help reduce costs in the system and prevent kind of a critical event from happening. It's hard to think about going and doing that when you're worried about, where am I going to sleep at night? How am I going to eat tonight? How am I going to keep the lights on? And how am I going to avoid eviction? Things like that. So really a lot of opportunity for us to do different things, but our program that we submitted and received approval for is really more specific to that housing piece of treating the whole person, and that hierarchy of needs. We know that safety, security, and a stable environment to live is one of the critical fundamental needs that we all have. So really wanted to take a look at that component of the social determinants of health, the health related social needs kind of continuum, and focus some efforts there and move up after we're successfully able to implement programming to address that piece for those that need it. Before we get into the details, just a note that we're kind of unique and lucky here in Arizona that we do actually have some experience in this space. So not using Medicaid dollars, which are federally matched and really highly regulated as far as how we can use Medicaid dollars. But we do administer a $27 million per year housing program that is funded through state-only dollars. So those are appropriated through our state general fund. We get those every year, and we are able to administer a housing benefit essentially for housing subsidies for our population of members who are designated with a serious mental illness. So that gives us some really good connections with the housing community that we have established. It gives us some really good data to go off of. It gives us an idea of the need, so that we can kind of take this new approval that we got to use Medicaid dollars and amplify what we've been able to do with these $27 million. Because while it might seem like a lot, it only goes so far. We have a wait list for these for these resources every year. We know that there's not enough just for this population, and we know that the majority of homeless and unhoused individuals in our state are actually not SMI individuals. They qualify as what's called general mental health. So we know there's a whole nother population bigger than what we're able to serve now that is in need of some of these services. So we're really excited to kind of amplify these efforts and coordinate with these efforts to make the dollars stretch as far as they can. This slide just, I won't read everything on here, but just notes that we've been kind of involved in working in this direction for a little bit of time now. In 2019, we launched what was called and what is called our Whole Person Care Initiative. So we have a few domains here that are listed on the screen that we are actively involved in trying to address. Housing insecurity, employment insecurity, criminal justice involvement, transportation insecurity, and social isolation being those domains. Our proposal that we received approval for actually also had a component where we would be able to coordinate services, housing services, and medical services prior to an individual's release from a carceral setting, which is not currently allowable either in the Medicaid regulations. That's kind of up next. We're currently negotiating that with our federal partners at CMS. So we're really excited to tack that feature onto this overarching housing waiver as well. But we have a lot on our plates just with the housing proposal. So excited to delve into all that's involved in, in that space prior to additional features coming on board. So it really fit well into this effort. We started on this journey in 2019, and then when we saw states across the country receiving approvals for using Title 19 Medicaid dollars for housing supports and actually being able to pay for housing for some of our members for a limited amount of time, granted, it was a no-brainer for us given our experience and given our the data that we have. It aligned perfectly with this program, so we're really excited to kind of help lead the charge at a national level towards approvals of this kind. So with all that context, what is the actual approval and where are we, and what all is involved in standing something like this up? How do we fund it? All of those questions will be answered in this slide deck, and then we'll have time for questions and answers. But we started with a few goals, right? So really, when we submitted this waiver, we wanted to increase positive health and well-being, increase the positive health outcomes for the target population. So really looking at those individuals going through really critical life transition periods, those that are actively homeless or that are at risk of homelessness, those that are transitioning out of institutions like carceral settings or other inpatient units that they might have been residing in for a long time, individuals transitioning out of the foster care system, things like that really is who we're looking at addressing with this program. And we really want to see those outcomes for those members increase and improve, because the data that we have kind of shows that those life situations are really ripe for critical events, right, and slipping in one direction or the other. So really making sure that there's a safe, stable place for individuals to transition, make those life transitions is going to be critical, and making sure that they're able to successfully transition into something that's more sustainable and that's safe. Based on their choice and their needs. We also wanted to see a reduction, of course, in the cost of care for individuals successfully housed. So one thing we see with this population is a matriculation through the emergency department for what we call avoidable inpatient stays, right, or encounters. So folks that might be living on the streets currently, one of the main places they receive healthcare, unfortunately, is when a critical event happens, they get admitted to a hospital. But if they had a safe place to reside and we're engaging in that preventative care on the front end, that hospitalization could have been avoided. So really focusing on those lower cost interventions on the front end to avoid some of those higher costs, more dangerous interactions on the back end. And then we wanted to reduce homelessness and maintain housing stability for the population. As was mentioned at the top of the meeting, we're in a housing crisis right now. There's no two ways about it. And we have a role in that as Medicaid. I think we're only part of the solution, but I do think we are part of the solution, which it makes it incumbent upon us to do something about it and use the resources that we have to the degree that we can to help address this, make those other resources go further, the dollar stretch a little further. But we do have some realities that we have to contend with. We have housing stock shortages in our state and across the country. So really, we're one piece, I think, in that solution. We have a few strategies that we're using throughout the demonstration waiver to help drive towards those goals. We want to strengthen homelessness outreach and service engagement, right? So I think that 30 days of in-reach prior to release is a big feature. We also received approval to pay for some outreach services, some generalized outreach services to the population that might not be currently engaged in services. They might have, these individuals might have been unhoused for a very long time and not have any interest in in engaging in services at the moment. So really allowing for some investment for staff time to go out, meet with those members where they're at, spend some time relationship building, doing some of those motivational interviewing strategies and tactics, so that when the member is ready to engage in these services, they're able to feel comfortable and have that relationship established, and then, you know, move into services or supports, whatever they need when they're ready. So really exciting, because we haven't historically been able to invest in that way in those kinds of outreach services. Our next strategy is probably the marquee item that we got approved that we're really excited about. We wanted to secure housing funding for members who are in that target population. So we did receive approval, and Liz will get into this in more detail in a moment, to fund up to 6 months of housing, so to actually pay for rent or a member's stay in different settings for up to 6 months, which is really exciting, because that transition period is so critical. If we're able to allow for folks to transition in a place that is safe. And then lastly, definitely not least, enhancing Medicaid wraparound supports and services for the target population. So the only way that 6-month stay is going to be successful is if there's a stated goal of housing permanency on the back end of that 6 months. And in order to make sure that happens, members are going to need different levels of care during that 6-month period. So really making sure we're able to give the level of care and the intensity of care that the member needs at any given time to make sure that 6 months is as successful as possible, because the last thing we want to do is waste resources, waste time, and have the member end up in the same exact position they were in prior to the 6 months. So really being thoughtful about using this as an intensive, time-limited support that can really drive towards permanency and and make those other those other benefits stretch a little bit further in the process. We are right at the beginning of this process. The waiver took about 1.5 years to negotiate and get approval for, but we're still very much at the beginning. It takes a lot to stand up a program like this. We've developed what we call a protocol, and we have a couple of other deliverables that still have to be approved by our federal partners at CMS. But implementation, planning, and execution is going to be the absolute key to whether this is successful or not. It's going to take our entire agency coming together, which they have and they are currently. It's going to take our provider community, our community-based organizations in the state, our managed care partners as well, all coming together, our tribal partners. I'm sure I'm leaving somebody else off, but coming together to establish processes, establish rates that are going to be sufficient, establish a workforce that's going to be sufficient to stand this program up. So that waiver approval really was the first domino that had to fall to allow for us to start on some of this work. So definitely don't want to undersell the tail that is implementation, planning, and go live is really the biggest lift in doing something like this. So little picture for where we're at and where we still have to go. With that, I'm going to stop talking because I've been talking at you for a little while. I'm going to turn it over to Liz to take us through some of the nuts and bolts of what we got approved and what we're thinking.
Thank you so much, Alex. And yeah, glad to be here. So you saw on the initial slide, I'm Liz Costa. I'm the Housing Program Administrator with Access. So currently oversee the rental assistance program that distributes the $27 million. And so thankful for the 1115 waiver approval. And now I get to kick into gear to help with the design of the interventions and then helping to establish criteria with the rest of the folks on our team at Access. So a part of that implementation protocol that CMS requires of us is really clearly establishing the eligibility criteria for who will be eligible for this benefit. We are going to narrow it down even further from what they originally expected of us. And I'll go into detail of that specific criteria in a little bit, but really the purpose for that is because we are in a demonstration period and we really do want to demonstrate success so that we can incorporate and embed these services into our system for the long term. The other thing we wanted to do was really focus in on a population that has high needs in order to be able to really wrap around health-related social needs services for them to help improve outcomes for them. So the criteria from CMS was that they must either be homeless or at risk of homelessness. So we are going to narrow it down to members must currently be experiencing homelessness. And then we're going to use our Z code. So we do have an expectation that our health plans require their providers to use the health-related social needs screening assessment tools, and then in turn put in Z codes for the related social determinants of health or health-related social needs into their claims. We know that this currently is underutilized right now as a system because there is not currently any funding attached to it. So we are going to use Z code for housing and security. And then also we work in partnership with our local continuum of care throughout Arizona. We have 3 of them to receive their homeless management information system data. So this is a really important part of what we're trying to do because the Z codes are underutilized. We can use that homeless management information system data to be able to verify that the member still meets the homelessness criteria, even though they do not have the Z code for housing and stability. And what we anticipate will occur though, because now we are tying interventions and resources to this Z code, is that we will see providers use it a lot more often because they'll know that potentially it'll help members have access to resources down the road. We also had to establish the clinical and social risk factor criteria. So what we've determined is that in order to receive this benefit initially, members must have the SMI designation. That is it's a current designation that's a statute in the state of Arizona. And in addition to that, they must also be diagnosed with a chronic health condition. We're currently internally working inside Access to look at research that can help us identify what are chronic conditions that are actually drivers of inpatient costs. And then from there, we would use those chronic health conditions to determine eligibility. Another, though, is we are working a lot in partnership with our correctional health facilities to try to reduce recidivism in the jail system. And we know that housing and addressing health-related social needs can be a key factor into helping to reduce recidivism. So a member may also have the SMI designation and then also be currently in a correctional health facility with a scheduled release date. We can go ahead and go to the next slide. So what we really did was, as Alex mentioned, we've had our rental assistance program in the state for quite some time. So we've been able to do a lot of data analytics around it and really work as a system to try to identify what the largest gaps are for helping a member access housing. And that's where we really got approved the outreach capabilities, which is it's key for us, because what happens right now is a member may have an SMI designation and then be assigned to a specific provider network organization for their case management services. But outreach is not currently a Medicaid covered service. So the members experiencing homelessness do not have the financial resources tied into the Medicaid system to have that case manager really get out into the community and try to locate them, establish relationship with them, and then help get them connected to services. So we did get this benefit approved through the waiver. And what we're looking at doing is working in partnership with community-based organizations and our regional behavioral health authorities to set up dedicated outreach providers who would be responsible for performing targeted outreach in the areas in which members who meet our eligibility criteria reside. The next, as Alex mentioned, very exciting for us, and we know it is only 6 months, and oftentimes people need much more than 6 months of rental assistance to truly be able to stabilize. But really, also, as you mentioned, it's really important that in this current housing crisis, we accept every resource that is available, and then we work in partnership with our community to try to maximize the utilization of that resource. So we did get approval to pay for up to 6 months of transitional housing. And what we're trying to do now, and what we have submitted in our implementation protocol to CMS, is break it down into 2 different interventions. The first, because something we've noticed through our data, is members who currently have been referred to even our own Access Housing program. So they've been referred for a permanent voucher or subsidy, who are currently living in unsheltered situations, are extremely challenging to be able to locate, help them get their necessary documents, help them have the time and space to attend their briefing, to get their voucher, really have a safe, stable location to reside while they go through the apartment searching process, all of those things. It's a definite gap. So we're working on coordinating the benefit of enhanced shelter. And that's where we're going to really work in partnership with community-based organizations, locations that are actually currently providing shelter services now, set some parameters around our expectations for the outcomes they're going to achieve, the training that they're going to have, and then onboard them as Access Medicaid providers under an enhanced shelter provider type, and then be able to draw down on our H2O dollars to be able to pay for their stay while they're there for no more than 6 months. Right now, our average length of stay in our shelters is about 90 days. So really the goal would be that they stay there for 90 days or less and then transition to a more permanent solution. The next is rental assistance. So we cannot go over 6 months for either intervention. So we're going to need to track if they stay in enhanced shelter for 2 months, then they would be eligible for up to 4 months of rental assistance. So that's something that's important to note. But what our plan on the rental assistance is we already have existing wait lists in our system of members who are waiting for housing. We can work with our statewide housing administrator to understand who meets H2O eligibility criteria, who is likely to be referred to a permanent subsidy within the 6-month period, and then actually pull them off our wait list sooner than they would if they had to wait, and move them into their own apartment following our regular protocols, so that, and using the H2O rental assistance dollars to pay the rent for that temporary stay. Until then, their permanent subsidy becomes available because now they've moved up on the wait list within that period of time. And then they can just transition in place in the apartment that they're in. So I know there may be some questions about that, so we'll go into it a little bit further if there are at the end of the presentation. But we also were approved for one-time transition moving costs. So oftentimes members have the voucher, but they don't have the ability to pay for the deposit, or maybe there's a first and last month's rent that's due that they cannot come up with. So we'll be able to address that need using these dollars. Home accessibility and modifications, and then also remediation. So if folks are familiar with permanent supportive housing, there are often times when a member's unit may become uninhabitable due to behavioral health issues or concerns or hoarding concerns. And so through this, we would have the dollars to be able to pay for remediation so that we can help with stabilization in the unit that they're in. And then also it really helps establish our relationship with landlords in the community when we can come in and support remediation of their units. And then the next, as Alex mentioned, really important are those support services. So we also got approved to do pre-tenancy and tenancy support services, where we'll have dedicated staff members who are trained in the SAMHSA model that's evidence-based towards permanent supportive housing. They're trained in that model. They follow those low staff to member ratios. They're out in the community working directly with members to help them find apartments. And then the key thing for the housing tenancy is once they've now moved into their unit, really staying with them until the member has stabilized in housing. So helping them understand the terms of their lease, how to be a good tenant, how to be a good neighbor, address any kind of challenges with the process of change from moving from homelessness into housing, and things like that that focus on stabilization. We can go next slide. Another important thing to note is we've gone into consideration for contracting with a third-party administrator. So we did a lot of stakeholder sessions with our community-based organizations when this was first approved to really ask, hey, what's the best way for us to implement this? What's going to work for you all? We know we need to advance our provider network by really engaging our community-based organizations and having them on board as Medicaid providers in order to help us meet the need across the state. So what do you think you would need? And that's really what led to our third-party administrator consideration, because a lot of our community-based organizations right now, as an example, some of those shelter settings, they are currently operating off of like grant funding structure. So they're not, doing full assessments and integrated care plans, and they're not submitting Medicaid claims for their billing, which we know can be a bit of an administrative process. So the idea is that we could RFP out for a third-party administrator who could serve a lot of the functions that we need for H2O. One of them would be to help onboard new community-based organizations and really do a lot of mentorship and hand-holding, walking them through the process of what it looks like, helping to address any concerns, and then also helping to establish eligibility for the state. So, when we look at trying to potentially use our managed care organizations for this, sometimes there can be concerns with standardization in the ways in which they implement programs. So if we did one third-party administrator, then we can establish some standardization. The other is coordinate the H2O services with health plans and integrated service providers. And then this is where we get to the develop a streamlined process for H2O providers to submit actions for reimbursement. So really what that might look like is the enhanced shelter continues to send their invoices in the same grant type structure process that they're very familiar with, but then our third-party administrator would use a crosswalk that Access creates to actually change that invoice into a Medicaid claim. An example of that is, we would use potentially our H0044 supported housing HICPIC code to be able to reimburse the rental assistance. And so the third-party administrator would turn invoices into those types of codes, using our crosswalk. Another thing that we would look for them to do is monitor and track our H2O service utilization and data. So the members resided in enhanced shelter for a maximum of 2 months. They have 4 months left in rental assistance. So obviously that's going to require a lot of work around, tracking of data and utilization to be able to ensure that we're not administering the benefit beyond what's approved. So we would ask for them to do that, and then also provide technical assistance to our providers. We can go next slide. So this is a busy slide, but what we've done here is look at general provider qualifications from all of our different interventions. So our outreach intervention, our shelter intervention, rental assistance intervention. We've pulled the general provider qualifications and our expectations and placed them on the slide. So one of the key things for achieving success through these interventions is really ensuring low staff to member ratios. Because often right now, case managers are serving high caseload ratios. They're responsible for helping members address psychiatric needs, get medications, apply for housing. So we really want to fine tune their expectations to specifically be addressing health-related social needs, and then also have low staff to member ratios so they can really have the time and capacity to get out in the community, develop that relationship, help to develop a care plan, and help to really meet the members' needs. The other thing is that we want to ensure they're skilled and trained in our PRPAR or another access health-related social needs assessment tool. Really important is that continued integration and collaboration with the local continuums of care. So we do have an expectation that they'll participate in those local continuum of care committees so that we can really be prioritizing in the same manner and coordinating efforts with them. That they'll use the homeless management information system for tracking, because often right now Medicaid is using an electronic health record that doesn't speak to the homeless management information system. So we could really have like 2 major fund sources working on the same member and not really collaborating. So we want them to use the HMIS system for H2O so that we can make sure that we're talking to that system so we can see what kind of services are being implemented. Really important too, because we'll be putting up a benefit that pays for housing. So we also, I'm going to just kind of skip down, have that we're going to have an expectation for that they become CARF accredited, that for community housing and shelters. We're going to set up a new ADHS license. So an Arizona Department of Health Services license for the state. They're the ones who do our physical inspections at locations in which we have members live. So there'll be a new licensure type so we can make sure we're getting out and doing quality physical inspections to make sure it meets our criteria. And then also have that CARF accreditation. And we can go next slide, and I believe I pass it back to Alex.
Awesome. Thanks so much, Liz. So that was a lot. But the multi-million-dollar question is, how do we pay for it, right? That's always the first, second, and third question, it seems like, before, how do we do it? For those that, might not be familiar, Medicaid is a state-federal partnership. So every state has a federal, what's called an FMAP, a federal medical assistance percentage. So in Arizona, what that looks like is it's about a 70-30 split. So for every $1 or so the state puts in, the federal government kicks in about $3 for all the services that we provide to our members. When we received approval for this, essentially what happened is housing now became a Medicaid benefit for those that qualify, right? Which is really important because that means that we need to come up with a state match for the 30, 24-ish, between 24 and 30% match. CMS has this concept that's called Designated State Health Programs, or DSHP is what we call it, because we live in acronym soup. And essentially what this allows for a state to do is take local or county-based health initiative funding and ask the federal government to federalize it. So to get that FMAP, that 70% on top of the expenditures that are made for that local funding, and then use those federal dollars essentially as the state match for these kinds of programs, these new innovative programs. So we availed ourselves of that funding structure. There's also some requirement that you use some non-DSHP funding as well. So there is some kind of skin in the game, if you will, or some, definite like clean, like state money, right? That isn't attributed to federalizing any of these local programs. Usually that's going to look like general fund or provider tax revenue, something like that. There is a lot of red tape using this option. The benefit is you don't have to fork up as much money from the state side, the actual state coffers. But there is some red tape. There's some prohibited expenditures. You have to submit what's called a claiming protocol. But it's very exciting for us because it means we can make our state dollars stretch even further, which is really exciting. There's also some carrots that CMS implemented as a result of this approval. There were some thresholds that we had to agree to meet on our Medicaid rates that were attached to the Medicare rates that are set. So we had to kind of promise that during the demonstration period, we would need to move further towards the Medicare rate by a set percentage if any of our rate categories in our OB, our behavioral health, or our primary care rate categories fell below 80% of the Medicare rate for that category of service. We also, as part of this approval, had operate under what's called a capped hypothetical budget neutrality test. That's a nightmare of a sentence, I know. But basically, for intents and purposes, that serves as a top funding limit for these services. So that's part of the consideration when we're talking about what services to provide, what populations we're going to provide services. We don't want to kind of overwhelm the provider system, this community-based organization networks, with an untenable amount of increased referrals. That's part of why we need to start small and with a more acute population, but we also don't want to blow the budget, right? So we need to make sure that we're able to get some good data on, how much this is going to cost. It's a brand new benefit, so it's a really new frontier for us and for Medicaid programs across the country. So really, really being thoughtful there, because under this funding structure, we do have about $96 million a year for program costs, which again sounds like a lot of money, but as we kind of indicated at the top of the meeting, it costs a lot to house folks and to provide them services. So lots of work to do there, but we're really excited to get some lead time on that data so that we can see how much wider can we open this benefit. That's the goal, is to open it to everyone, but better to start small and successful than have it fall flat. We also have to set up what's called a Medicaid eligibility group, which I won't go into, but that's just a tracking feature, basically to track the expenditures here. And we can't, as a state, claim any savings under this model either. So a couple of kind of more nuanced and in the weeds notes on the funding side. I think what's most important here is that that left side, that left column, but did want to also note kind of what the funding structure looked like as well. For those that are interested, all 1115 waivers have to comply with what's called budget neutrality, meaning they can't cost the federal government more money than the waiver or than Medicaid would have cost if we didn't have the waiver. So we have to prove that it's going to be at least cost neutral to the federal government, if not less than what would have otherwise been spent on the population served. All right, so if we move to the next slide, I'll wrap this slide up pretty quickly. I think, this just notes that we have a lot of work to do still. We still have to receive approval on the service definitions, the population, the definition of our target population, what medical necessity means. We have to get approval on what rates we're going to be paying for these services. We have to edit our contracts. We have to develop policies. We have to figure out how we're going to bill, how we're going to, open up billing to our community-based organizations. So we have a lot of future work to do to engage our stakeholder groups that we've been working with around some of these details, as well as a lot of work internally to do to come up with some of the concepts based on that feedback. So lots of work. We're anticipating going live with this, hitting the on button in 2024. So October 2024. We knew we were going to need a little bit more time than just the approval to implement this, and all of this is contingent upon CMS approval. So I'm really working with our federal partners over there to make sure that this is a success. All right. I know that was a lot, so I'll stop sharing here on the screen. I'll put myself on mute. I have not looked at any of the chats, if any have come in, but I'll open up the screen so we can kind of see each other and go through any questions that you might have.
Alex and Liz, I wanted to thank you for an incredibly detailed and thorough presentation on the demonstration that you're doing. It looks like there's still a lot of work yet to be done, but the amount of progress you've made in a short time is extraordinary. And we all know that federal bureaucracy is, complex and time consuming to deal with. So maybe we can start with some questions about the funding, which we think are going to be interesting. So as you pointed out, the federal government will be funding up to 6 months of rent for these eligible individuals. You explained that there was going to be a way to select individuals off the existing housing wait list so you could transition them directly off the 6 months after that to the state-based rental voucher program. Could you explain that a little bit further? Is this intended to I guess not leave anyone in the lurch after the 6-month period has expired?
Yes, yeah, absolutely. So it's for the purpose of making sure that after the 6 months is expired, month 7 is going to occur, and they're going to be in a lease for that unit. So we want to make sure that there is a financial sustainable plan for them to not have to be, evicted from that location. The other thing is we do plan on using our own access housing program subsidy, but we also are looking to partner with our local continuum of cares, our local public housing authorities, to see who else might be interested in engaging with us in what we call like a bridge to permanency program. Because the more long-term subsidies we have available on the back end, the more individuals we're able to temporarily house using these rental assistance dollars. The other thing that's really beneficial is those we have grant utilization expectations. So on our HUD continuum of care programs, HUD really looks to them to spend 98% of their grant, and they're scored for that. So if we're able to set up a system where we already have members in housing, they already have completed HQS inspections, they have leases, then when the voucher becomes available, they can just transition that member in place, and then it would help their utilization as well.
Got it. So it sounds like it's accelerating existing waitlist people into housing. But that's a slightly different question from, is it housing additional people who might never have been housed if this demonstration never had existed? Do you have an estimate of the number of additional people who would find housing through this demonstration?
It's a good statement, I think, because no, it does not house new people who would not be housed. It does house people sooner. And then because regardless, it still is dependent upon having that long-term subsidy available, which those are limited. We're not getting any additional resources for those. The other thing it does, though, is, when members are on wait lists and they're not currently in housing, there's impact somewhere. Maybe they're cycling in the hospital system, having increased inpatient admissions. And so because we're going to be able to house them up to at least 6 months sooner, then hopefully we'll see reduction in some of those other higher level interventions they're using to try to stabilize in the meantime.
And I'll just add too, I think it's a really important point not to overlook is the rate limiting factor here is going to always be housing stock, right? However, it does provide an opportunity for organizations that are investing currently in that first 6 months to kind of push their funding down the line for that 6 months of like plug and play this funding and then make additional investments in placements and programming, which could have a downstream effect of creating more units, right? Additional resources that are available in that bottleneck that currently exists, that is our housing stock issue. And it also allows for additional money, right? And we know that a big reason behind the housing stock issue is not necessarily a lack of facilities, of houses necessarily, of apartment units necessarily. It's a lack of landlords and partners that are willing to take some of those subsidies because there's a market incentive to go private and take a higher paying client in that instance. So in those ways, we're hoping to see some downstream effects that will we can infuse these dollars to kind of amplify what does exist currently and potentially have a downstream effect of creating more opportunity, more available resources.
Great. So for our audience, again, feel free to enter your questions into the chat and we'll try to get to as many as we can in the short time we have remaining. If I can ask another clarifying question. So, one model that was brought up by our current Hawaii Governor, Josh Green, when he was in the Hawaii State Senate, was this idea that it could be as seamless as an emergency room doctor writing a prescription for housing. But it doesn't sound like it's going to be quite that seamless under your implementation plan. Could you describe how an individual would, could you play the tape and tell the story of how an individual would get housed under this demonstration?
Yeah, I think because we are in a demonstration period, it's really important that we're focusing on a very specific eligible population. So I think, the ER doctor may not have all the criteria that is used to try to establish eligibility, because the member is going to need to be verified as experiencing homelessness. They're going to need to have the SMI designation, approved chronic health conditions, or be in the correctional health facility and scheduled for release. So because of that, we really have to establish eligibility criteria at the state level and then communicate out, these are the members who are eligible to our managed care organizations, and then also to just to our and potentially to our third-party administrator who will help also coordinate the benefit. So from there, the managed care organizations will have the list of individuals who are eligible. They can look within their system to see, is this member currently engaged with one of our providers? If yes, I can communicate to them that they're eligible for a temporary stay in an enhanced shelter. They're eligible for up to 6 months of rental assistance. And so from there, we would really dispatch either our outreach team or their current case manager or one of our tenancy support staff to go out into the community, meet with the member, confirm that they're interested in receiving these services, create a care plan, and then if they're not on the housing wait list, they would work on helping them get on the housing wait list and then get referred over to an enhanced shelter.
Got it. Thank you. If we were to zoom out a little bit and look at the problem of homelessness in Arizona on the whole, this is going to be a significant part of the solution because, as you pointed out, Medicaid is such a significant source of funding. But ultimately, what fraction of the issue do you think this will address? And as for the remainder that this program, this demonstration would not address, how do you think that Arizona would be able to close that gap and get to, functional zero or a very minimal, de minimis homelessness problem in the long term?
Yeah, that's a great question. I'll take a stab at it, Alex, but then So what part of the overall housing crisis will this address? I think, it's really challenging to try to come up with an exact percentage, but I will say that we know there's a gap in funding for enhanced shelter right now. And there also is a gap in really standardizing the expectations for those shelters. So in using the Medicaid resources, the access to clinical resources and training, we can really, implement some standardization and expectations for the ways in which those shelters are operating across the state. Whether some of their funding is coming from Medicaid through this benefit, or they're also funded through HUD Continuum of Care programs, emergency solution grant dollars. So really it's this idea that we can craft our protocol that gets good outcomes, is based on best practice, and then implement that with other fund sources across the state. I think where we have the greatest position to make serious change in the Medicaid system is really in the wraparound supports, because a part of permanent supportive housing is the supportive services. So we have other state agencies like the Arizona Department of Housing, and they just received $150 million in State Housing Trust Fund to do property acquisition, renovation, to really bring on the bricks and mortar units of housing that we need, but they don't do support services. So when we really build out our pre-tenancy, tenancy support services, we use our rehabilitation services that are eligible to be billed as covered behavioral health services. We can get trained staff out into the community who are providing the support services across the state, regardless of what housing resource is currently being used to pay for their rental subsidy. So when it comes to the support services side of what Medicaid could do, I would say we have potential of helping to do about 60% of the support service need, because that's really, I think where the most amount of resource is currently at.
Yeah, and I'll just tack on, I think, Liz alluded to this, but it's going to be a government-wide effort, right? And really need a lot of synergy when it comes to how we're aligning our goals, how we're aligning the investments we're making, and ensuring that we're not duplicating efforts, and that funding is being stretched as far as possible, because it is limited. Just like I was saying, if you provide somebody with healthcare with no housing, that's a recipe for disaster for that member, right? Same thing on the inverse. If you provide housing with no healthcare, that's going to be equally disastrous, because the living skills that are necessary, the budgeting skills, anything that the member needs in their unique situation is going unaddressed. So really, I think partnering and feeling out, continue to feel out. We are at the cutting edge of this. Housing is healthcare, right? But how far, like how much of housing is healthcare, right? Is it forever? Is it for a time limited period? The data that we see, the best practices that we see, indicate that about up to 18 months of housing is effective for getting somebody kind of back on their feet and towards a sustainable living situation that is permanent. So we're in a demonstration period right now. We have 6 months to deliver this benefit, and we have a 5-year demonstration period to say to CMS, hey, we did this for 6 months. Look how effective it was. Now let us do it for 18 months, and we'll show you how much more effective it is. And then we can move forward and say, all right, let us do this permanently. Don't make us reapply for this every 5 years, right? This needs to be a permanent part of our program, so that we can sort of start to address those members that are in this situation. And over time, kind of they'll go through the system, they'll go through all of these supports that we're hoping to set up and we're looking to set up. And then more and more, you'll see people come out on the back end successfully housed, right, in a permanent situation. So that's going to take a lot of time to make sure that we're doing this the right way, to expand to all the populations that need it, and to have time for all those populations to go through the process. So it really is going to be a society-wide and a government-wide effort to address the housing problem. But we do have a role in it, and a significant one at that, as Medicaid.
Well, I think that's a great explanation for how this program will be part of that longer term vision. Increasing funding for enhanced shelters and establishing standards for those shelters and establishing the pipeline by which organizations will be able to take vulnerable individuals, homeless individuals, and easily transition them into housing. Those are the thorniest issues that we have today, frankly. And so congratulations on Arizona's receiving this waiver. Hawaii, I understand, will be applying for it, and I know many other states are probably interested in applying for it too. And I hope that we and those other states will learn a lot from Arizona's experience. And so unfortunately, that's all the time we have today, but I wanted to finally thank Alex, Elizabeth, and Shreya again for joining us today and sharing your insights, and all the best, and we hope to continue the conversation.
Awesome. Thanks so much for having us, and please feel free to reach out if you have any questions or follow up.
Great. Thank you again. And thank you for joining our Homes webinar.